Most men, when they first notice it, say nothing. Not to their doctor, not to their partner, not even to themselves, not really. They file it away under getting older and move on. They tell themselves it's stress. They tell themselves it's fatigue. They tell themselves it will pass. And sometimes it does pass, for a while. But here is what almost no one tells these men, and what I want to share with you today, clearly and directly, because I believe you deserve to understand what may actually be happening inside your body. In many cases, what feels like a sexual problem is not primarily a sexual problem at all. It is a vascular signal, a message from your circulatory system, a warning that your blood vessels may be changing in ways that matter far beyond the bedroom, and that if you understand what that signal means, you have a genuine opportunity to do something about it before it becomes something far more serious. I am Dr. Katharina Neumann, and I have been working with men over 50 for more than 2 decades. What I'm going to walk you through today is one of the most consistently misunderstood connections in men's health. By the end of this video, you will understand why this connection exists, what it means for you specifically, and, most importantly, what your real options are. Stay with me, because the part that surprises most men comes in just a few minutes. Let me start with something that might feel uncomfortable to say out loud, but which I think is worth naming directly. Erectile difficulty is extraordinarily common among men over 50. The numbers vary depending on the study, but most research suggests that somewhere between 40 and 60% of men in this age group experience it to some degree. Some men experience it occasionally. Others find that it has become a reliable pattern, and a significant number have simply stopped expecting things to work the way they once did. What is striking, though, is how rarely these men connect what is happening in the bedroom to what might be happening in their cardiovascular system. When I sit across from a patient in his mid-50s or 60s and he describes this issue, I always ask the same question. Has anyone ever talked to you about the relationship between this and your heart health? Almost universally, the answer is no. And that gap, that missing conversation, is exactly why I wanted to make this video. Here is the physiology, explained in plain language. An erection is, at its core, a vascular event. It depends entirely on blood flow. When arousal occurs, signals travel through the nervous system and trigger the arteries supplying the penis to relax and dilate, allowing a rapid increase in blood flow. The tissue fills, pressure builds, and an erection forms. For this to work properly, the arteries must be healthy. They must be flexible. They must be responsive. They must be able to dilate quickly and fully on demand. Now here is what becomes critical to understand. The arteries that supply the penis are among the smallest in the body. They are significantly narrower than the coronary arteries that supply the heart. And this size difference matters enormously. When the arteries in the body begin to stiffen, when plaque slowly accumulates, when the vessel walls lose their flexibility, when blood flow begins to be restricted, the smaller arteries are affected first. They simply cannot compensate as effectively as larger vessels can. This means that in many men, the erectile arteries begin to show dysfunction years before the coronary arteries show obvious problems. The body, in other words, sends a warning signal through sexual function long before a cardiologist would flag anything on a standard examination. I want to say that again because it is the central point of this entire video. For a significant number of men, erectile difficulty is the first clinical sign that something is changing in their cardiovascular system. Not a coincidence, not an isolated problem, but an early signal that often precedes more serious cardiovascular events by years. Now, I want to be careful here, because I am not suggesting that every man who experiences this issue has a heart problem waiting to happen. That is not accurate, and it would not be responsible for me to say it. There are many reasons why this issue can occur. Psychological factors play a significant role. Stress, anxiety, relationship dynamics, and depression can all affect sexual function directly and powerfully. Hormonal changes, particularly declining testosterone, which we will come back to in a moment, are a very real contributor. Medications that millions of men take every day can affect blood flow and nerve signaling in ways that most men are never told about. Sleep disruption, which is extraordinarily common after 50, suppresses the hormones that support sexual function overnight. Poor nutrition, reduced physical activity, alcohol consumption, and smoking all play roles. The vascular pathway is one pathway among several, but it is one of the most important and one of the most frequently overlooked. And here is what makes it particularly significant. In many cases, the vascular pathway and the other pathways are not competing explanations. They are compounding ones. A man whose arteries are beginning to stiffen is also often a man who is sleeping poorly, whose testosterone has declined, who is taking 1 or 2 medications with relevant side effects, and who has been under chronic stress for several years. These factors do not simply add together, they amplify one another. Keep watching, because in just a moment, I want to show you something specific about how doctors identify which pathway is at work and why this distinction changes everything about what you should do next. There is a clinical concept that I find genuinely useful for helping men understand this, and it is called endothelial function. The endothelium is the thin layer of cells that lines every blood vessel in your body. It is not passive tissue, it is metabolically active. It produces substances that regulate how your arteries dilate and constrict, how much inflammation occurs in the vessel walls, how easily platelets clump together, and how smoothly blood flows. When the endothelium is healthy, arteries are flexible and responsive. When endothelial function is impaired, a condition called endothelial dysfunction, arteries begin to lose that responsiveness. They become stiffer, they dilate less efficiently, blood flow becomes less reliable. And here is the connection that most men never hear about. Endothelial dysfunction is both an early driver of erectile difficulty and an early driver of cardiovascular disease. The same underlying process, the same deterioration of the vessel lining, contributes to both conditions. This is why researchers and cardiologists increasingly refer to erectile dysfunction as a sentinel event for cardiovascular risk. Not a cause of heart disease, but a sign that the same process that leads to heart disease may already be underway. One research framework that has gained significant traction puts it this way: the size of the artery determines the timing of the symptom. Problems in penile arteries manifest as erectile difficulty. Problems in coronary arteries manifest as chest pain or a cardiac event. And because the penile arteries are smaller, their symptoms often come first. The window between these two signals, in many cases measured in years, is not a threat, it is an opportunity. Let me tell you about something I see in my practice that I think many of you will recognize. A man comes in for a routine checkup. He's 57, maybe 62. His blood pressure is mildly elevated, but nothing his previous doctor felt needed immediate attention. His cholesterol is borderline. He's a few kilograms heavier than he was a decade ago, nothing alarming on paper. At some point during the visit, he mentions, almost as an aside, almost apologetically, that things have not been quite right in that department for a year or two. He frames it as probably just stress or age. He does not seem to think it is why he came in, but for me, that mention changes the entire nature of the visit, because what he's describing is not a side issue. It is a data point, a clinically meaningful signal that the cardiovascular picture I have been building in my mind needs to be taken more seriously. It means I want to look more carefully at his endothelial health, at his inflammatory markers, at how his arteries are actually functioning, not just what his cholesterol number says on paper. And often, when we do look more carefully, we find things that were not visible before. Not dramatic things necessarily, not emergencies, but early-stage changes that, addressed at this point, can be genuinely meaningful for the next 15 or 20 years of his health. This is what I mean when I say this signal is an opportunity. Now I want to talk about something that I think a lot of men get wrong, and I say this with genuine compassion, because the mistake is completely understandable. When men experience this issue and finally decide to do something about it, the most common first response is to look for a solution that is specifically targeted at the sexual symptom. Medications like sildenafil or tadalafil, the active ingredients in drugs like Viagra and Cialis, are well known, widely prescribed, and they work for many men. They do not address the underlying vascular process, but they can restore function in the short term, and for many men, that relief is real and meaningful. The mistake is not in using those medications. The mistake is in stopping the conversation there. Because if the underlying signal, the one pointing toward vascular health, is never investigated and never addressed, then what is happening in the arteries continues to progress. The medication manages the symptom. The condition that the symptom is signaling continues to evolve, quietly and invisibly in the background. I have seen men who managed their symptoms effectively for 5 or 6 years before a cardiac event made it clear that the original signal had been trying to tell them something important all along. I am not sharing that to frighten you. I am sharing it because I want you to understand the difference between treating a symptom and understanding what the symptom means. So what should a man in this situation actually do? The first thing, and I mean the very first thing, is to have an honest conversation with a physician who takes this connection seriously. Not all do. Medical training has historically treated sexual health and cardiovascular health as separate domains, and some doctors will still address them in isolation. If your doctor dismisses the connection or does not want to explore it, it is entirely reasonable to seek a second perspective. When you do have that conversation, there are specific things worth asking about. Inflammatory markers, including high-sensitivity C-reactive protein, can give a picture of underlying vascular inflammation that a standard cholesterol panel does not capture. Endothelial function can be assessed more directly through tests that measure how well arteries dilate in response to stimulation. Blood pressure at rest tells you only part of the story. How blood pressure responds to exertion can be equally informative. And a full hormonal panel, which goes beyond simply measuring total testosterone, can reveal patterns that a single number will miss. These are not exotic tests. They are available. They simply require a doctor who is asking the right questions. I also want to spend a moment on something that almost every man in this situation can begin doing immediately, without waiting for any test or any prescription. The endothelium, that vessel lining I described earlier, is remarkably responsive to lifestyle. This is not wishful thinking, it is well-established physiology. Aerobic exercise has a direct and measurable positive effect on endothelial function. It increases the production of nitric oxide, which is the primary signaling molecule that causes arteries to dilate. It reduces inflammation. It improves the flexibility of vessel walls. Even modest increases in physical activity, walking briskly for 30 to 40 minutes most days, produce meaningful changes in vascular health within weeks. Dietary patterns matter significantly. The Mediterranean-style diet, which emphasizes vegetables, legumes, fish, olive oil, and limited red meat and processed foods, has some of the most consistent evidence behind it for cardiovascular and endothelial health. This is not about extreme restriction. It is about a consistent pattern of choices that reduce inflammatory load and support the biochemistry of healthy blood vessels. Sleep, which I mentioned earlier, deserves particular attention. During deep sleep, the body releases testosterone and growth hormone, both of which support vascular repair and maintenance. Chronic sleep disruption, which is extremely common in men over 50, disrupts this process and contributes directly to both hormonal decline and endothelial dysfunction. If you are waking repeatedly through the night, or if you feel exhausted despite what seems like adequate time in bed, this is worth investigating seriously, not simply accepting as a fact of aging. Smoking damages the endothelium directly and dramatically. If there is one lifestyle factor with the most unambiguous and dose-dependent negative effect on vascular health, this is it. Alcohol, particularly in larger quantities, suppresses testosterone production and impairs the quality of sleep. Moderate consumption, defined as no more than 1 to 2 drinks per day, appears to have a neutral or mildly positive effect in some studies, but regular, heavier drinking consistently worsens both vascular and hormonal health. None of these are surprising, but the reason I raise them in this specific context is important. These are not generic "be healthier" recommendations. They are targeted interventions that directly address the biological mechanisms underlying what you are experiencing. When a man understands that his morning walk is directly improving the function of his arterial lining, not just his fitness, the motivation to maintain the habit tends to be quite different. There is one more thing I want to address before I close, because I hear about it often enough that I think it deserves direct attention. Many men who experience this issue feel a particular kind of silence around it, a reluctance to bring it up with anyone, doctor, partner, friend. There is a sense that this problem is somehow about identity, about masculinity, about something fundamental that is slipping. I want to say clearly, that feeling is understandable. And it is also one of the things that can delay a man from getting information that could genuinely matter for his long-term health. What I hope this video has done is shift the frame slightly. The signal your body may be sending is not a verdict. It is not a conclusion. It is not confirmation that something important is ending. It is, in many cases, an early warning from a system that is still working, still communicating with you, still giving you information you can use. The men I have seen make the most meaningful progress are not the ones who had the mildest cases. They are the ones who took the signal seriously at the right moment, who had the conversation they had been avoiding, who found that the underlying picture, once clearly understood, was genuinely addressable. That conversation begins with understanding what the signal means, which is exactly what today has been about. If you found this useful, there is one more topic I think is directly connected to everything we discussed today, and it explains something that happens in the body during sleep that most men over 50 do not realize is affecting their hormones every single night. I will cover that in detail in the next video.